Good morning. My name is Will Austin. I'm the Town Clerk at the Barnstaple Town Council and the independent chair of today's session. I will start out just by saying that the entire session, I believe, is being audio recorded. So just so that you're aware of that. And some points on facilities. So the toilets, first of all, out at the back here through the rear door. The gents is just out at the back here. There's a disabled loo right down at the end of the corridor. I'm told, there are 3 steps down, but I'm told there's a lift down in case anybody needs that down the steps. But I'm sure there's somebody here who can help out in case there are any problems with that. And the ladies is upstairs, so the accessible loo becomes more important there. The fire escapes, if there is a fire alarm, and there isn't one planned today, if there is an alarm, then please leave via that door if available and head towards your car in the car park. There will be no assembly point. As I say, no fire drill planned. There are some teas and coffees at the back of the hall. Please help yourself to any of that. But if the NHS refreshments don't quite take your fancy, there is also, I think, a cafe outside. Don't miss out on the important business of the day. I have managed to silence my phone, and I'd ask you to do the same for the duration of this session. So just to run through very quickly what this is about and what the running order is. I'm doing my introduction in 5 minutes. I've probably overrun, but I'll try not to. We'll have a couple of presentations, one on the Sustainability and Transformation Plan, and that will be from, on my right, Andy Ibbs, and then a second presentation from Chris Bowman, and those will take, I think, about 20-25 minutes in total. There will then be an opportunity for an open plenary feedback section. It's scheduled for about 30 minutes. We'll see how things go. When you make the points, make them quickly, please, so that we get everything in. I want to get as much as possible in terms of feedback today. The way the event has been set up, there are table discussions there on both the STP and the ASR. So that's the Acute Services Review, sorry, for those who don't like the jargon. So those are scheduled for 15 and 45 minutes respectively. That's how we're going to play it this morning. It may not be quite your preferred way of playing it, but that's how I've been asked to chair the session today, so that's how we're going to do it. I've got a quick question over here. I'm not going to take a lot of questions.
Why has there been so little time allocated for questions compared to the tabletop?
Well, as I say, we'll try to be flexible with that, but I know that the intention today, if I just run through the aims of the morning, hopefully it'll become a bit clearer. But actually, I'm going to hijack at this point and just say to everybody that whatever the format of today's workshop, the Town Council has organised an open public meeting on the 28th of March, 7 o'clock at Barnstaple Guildhall, to be addressed by Alison Diamond, Chief Executive at MDHT, and she will take questions and comments, whatever they might be, and we'll try and make that as open-ended as possible as long as I get home for my dinner at some point. So that will be a further opportunity. So if you don't like today, you've got another opportunity. Just to introduce the aim of today's event, to introduce the STP, check people understand its purpose and priorities, find out what you feel should be the criteria for changing services to ensure they remain safe and sustainable. And that's what the tabletop discussions are about. There'll be one for each area of the reviews, I believe. To identify what questions people have about the STP and the Acute Services Review and find out what concerns people may have. So I've got this event to chair today. I've agreed to come and do it, and we're going to stick as rigidly as possible to the timing so that we finish on time. I've got that much time. If we can flex things a bit to extend the plenary session, we'll do that. But that's as much as I can offer. Quick word about the facilitators. So at the table discussions, Each table will be led by a facilitator, and their role will be carried out by a mix of staff from the NHS across North Devon. And I'm told there are 7 of you. Please could you identify yourselves? Maybe stand up will be helpful so people can see who you are. Look like more than 7 to me, but great, lovely. Okay. So that's all I was going to say as an introduction. Dave, we got through 5 minutes. Well done.
Yeah. On the question of separate tables, I would argue that we should not have separate tables and that we should keep the general discussion going because the public has lots of questions. That's been seen in meeting after meeting. And therefore, I think it's important that we, the public, are able to question the people at the table that you're chairing.
Lovely, here you point, Dave.
I totally agree with that.
My apologies, ladies and gentlemen, that's not how I've been asked to chair the meeting today. I repeat. I hear what you're saying. I repeat that I have arranged a separate public meeting at which you can all come and have your say. Well, because that's what my colleagues in the NHS want to do. We added to that with an open consultation. You are eating into your plenary session. That's all I'm saying.
Today to ask questions of people who put this plan together. We lost the reports and staff. I need to ask the questions. I need to get the answers.
And right now, sir, you're eating into that opportunity. There will be that opportunity in the plenary session. And everybody who stands up...
Everybody who wants to do the tabletop discussion. Nobody wants to do the tabletop discussion.
We all want to do
tabletop discussion.
I need direct answers, not a piece of paper that goes back to I've never seen again. I want answers to that.
And the person sitting on my table is employed by the NHS as an engagement officer. How is that relevant to what's going on with our NHS?
I hope...
How is she going to be able to answer questions?
Ladies and gentlemen, can we just calm things down a bit in the hall? I'm sure colleagues in the NHS hear your point about the format of today's session. All I can offer as the independent chair is a separate opportunity to engage in just the kind of question and answer that you've been asking for, or many of you have been asking for this morning. Dave, you've had your say. So thank you. We won't be taking
If the NHS is really listening to us, and I presume these are representatives of the NHS in our area, could we not have a democratic vote in the hall to see who would like to have an extended question and answer time rather than the tabletop discussion with somebody who doesn't actually come from our local area?
No, that's the answer to that question. I think that I've been asked to carry this session out in a certain format, and that's how we're going to do it. If you're desperately unhappy with that and you really don't want the opportunity to feed in at all today, well, there is only one other option, I'm afraid.
So that doesn't really bode well for the whole consultation process. We're not going to...
Okay, that's a point you will need to make at some point. And you may want to make that in the plenary session, which is getting shorter and shorter at this point, by the way.
What do our representatives from the NHS feel about this? Why will they not answer this point? We're not asking you.
Well, shall we ask that question at the plenary session, shall we?
No,
So we can get into the
Will they agree to a democratic decision?
There's 2 reasons why we want to have both a plenary session and tabletop sessions. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9 tables here. In that time for the question and answer session, that means there can be the tabletop session, that means there are 9 conversations going on. 9 times more than if we have a plenary session. There is a facilitator at each table that will be recorded with that. We'll get together, we'll get 9 times more information. The other reason for having tabletop discussions is that it enables the quiet voices to be heard. Okay? It enables the quiet voices to be heard. There'll be some people here who might feel nervous standing up and talking from 80 people. On a table of 8, they feel less nervous. So that's how it needs to happen.
Has anybody got spoken? Are you feeling nervous about making massive cuts?
Okay, ladies and gentlemen, I think we've had a discussion, and we've had a discussion as far as we have. You've taken 15 minutes out of the plenary session already. I encourage you to be quiet now. We will need to finish on time, and so we'll carry on with the process. If you're not happy with it, you will undoubtedly make your voices heard to the NHS. But I encourage you to do that after the event, when you've had the opportunity to input as far as there is an opportunity today. So let's crack on with the presentations, starting with one on the STP from Andy Ibbs. Andy, do you want to introduce yourself?
Okay, thanks. Thanks a lot for coming here. Thanks so much for the time and effort into coming here. I think it's worth pointing out, you may feel that there are faults with this process, but compared with what used to happen when I started working for the NHS, this is miles and miles ahead of what we used to do. Okay. So we're here to talk about the STP.
Sorry, could you just introduce yourself?
Oh, sorry, I thought you would. I'm Andy Ibbs. I'm Director of Operations and Strategy at Northern Devon Healthcare Trust. I've worked there for the last 5 years, and I've worked in the NHS for actually over 30 years now.
And in a private company.
Now, I've been told to get through the presentation as quickly as possible.
a chance to come here to listen and learn? Can you please have a get on with it?
Thank you.
Thank you.
So,
The microphone a bit closer to your mouth so we can all hear what you're
this is the agenda for now. As Ian pointed out, we've already eaten this quite a lot, so I'll go through the presentation as quickly as I can, so that we can get the onto the plenary session
Can I
as
just
soon as
say,
possible.
sorry, there's a gentleman at the back that's having trouble hearing you, so could you just...
Is that better? In fact, I'll stand over here. That's even further away. Okay, so we're on to the presentations. What today is about explaining why we're having to develop a sustainability and transformation plan, and why, as a result of that, we are reviewing hospital and specialist services. We want to hear what is important to you. Obviously, we've got a reasonable idea so far, given what's been going on social media and in the mainstream media, etc., and from our previous meeting. But it's really important to get your individual views. And then we'll explain how we'll use the feedback to inform those plans. The most important thing to stress right now, there aren't any plans in the bottom drawer that we're waiting to pull out.
Yeah, like Holmesworthy.
And also we'll let you know how you can remain involved over this process. This is just the very, very start of the process. So, there are 44 sustainability and transformation plans across England. Devon, that being the old county of Devon, so including Torbay and Plymouth, is one. It's the first time in a long, long time that all the NHS providers and the local authorities have come together to work on one plan, rather than, to be frank, what's happened previously is organisations have often been pitted against each other. It's necessary. Chris will explain why clinically it's necessary, but also financially. The size of the challenge facing the whole of the NHS, but then in particular makes that essential. And what we do know about the planning is that it has to deliver better integration between health and social care, better meeting the needs of our ageing population. Devon is some about 25 years ahead of the rest of the country in terms of the proportion of older people it has, how we meet the increasing demand on services, and how we better use technology to deliver the service. That's all the organisations involved. A lot of NHS ones that you'll see, and they're pretty self-explanatory what they do. Just very, very quickly, Live Well is a social enterprise that delivers community services in Plymouth, and you'll see there we've got GP practices and Health Watch. Devon Doctors, they deliver the out-of-house service for general practice, and Virgin Care deliver out-of-hospital children's services. So there's a brief video that will explain the case for change.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be more than £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton, Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on healthcare for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospitals, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition.
People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They are also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high-quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care, and get the best possible outcomes for local people.
Okay, so that explains some of the problems, the issues facing us. Just very quickly to give you some context, because this did provoke some questions at last event earlier. 500 million, what does that mean? Our total budget for the NHS in Devon is about 1.1 billion. Okay? And 150,000 people living with mental health problems. The overall population for the wider Devon is about 1.3 million. So in other words, more than 10%. So, in terms of the aims of the STP, we have three prime areas. The health and well-being, we need to actually try and prevent people getting ill in the first place. We need to recognise the demands of the care system and also these health inequalities. So it's a shocking statistic about ill and life expectancy. In terms of care quality, there is a variability in quality across the county for different services. There isn't one area that's particularly bad. Every area has some good and some bad areas. We need to get everywhere good quality. We need to give mental health the status and the equity that it deserves. And also the principle that there's no bed like your own bed. Financial sustainability, £557 million gap by 2021. Now, of course, it won't be that, because we're always doing things to try and make things more efficient, but that's if we do nothing. And that scale is like nothing else. It is proportionately larger than elsewhere in the country, and everywhere in the NHS is experiencing issues. So there will be impacts, but we also need to make sure that resources are fairly allocated across the county, which it is not the case at the moment. So we've got 7 priority areas, you'll see those. Today is concentrating on the circled one, the acute hospital and specialised services, but we are also working on all of those other areas. And with that, I'd like to hand over to Chris, if I may.
Andy. Chris Bowman is Deputy Medical Director at North Devon Healthcare Trust. He's promised me he'll get through this in hopefully about 5 minutes, so we can get into the cleaner.
Okay, can you all hear me? Yes. Yeah? Excellent. Okay, I am going to go through this quite rapidly and just re-emphasise what today is about, because that makes sense of what my presentation is about. We can confirm there has not been any agreement as to the outcome of this consultation process. We have not agreed options as to what are going to be put before you. Today is getting your input into the criteria which will inform that option appraisal process. And it's vital we have your input into that part of the process. Because and I will show you the criteria that we've come up with. We have our interpretation of what that means, but what we're really wanting from you today is what you think that should mean as far as you, the public, are concerned. So that's what it is about today. We're not here to discuss what the options are, because we don't know what the options are. And anyone who tells you they do, they don't. Okay? So, why are we doing this? Because, as it's been stated, we have a financial pressure. But not only that, we have an equally important staffing problem. 11% of consultant posts are unfilled. There are not the consultants out there to fill those posts. And those affect some very specialist services as well. Intervention radiology is one of those. And one of that is a key part of the service when we're talking about stroke management. So we've got to make the most of the resources that we have. I'm not going to take any questions during my presentation. That is not a quick question. I'm not going to. I'm happy to answer, but there's a whole. Everybody wants to ask questions. I'm not sure why I should.
We're just a few minutes away from the open questions now, and you can ask those any questions you like then.
Absolutely. I'm very happy to answer them. So, As I say, we do have issues around consultant staff, and it's not just the consultant staff, it's nurses, therapists, it's the whole workforce. We have shortages. These are national, and we feel that pressure locally as well. We know that the GP workforce, 25% of the GP workforce is going to retire within the next 10 years. Jeremy Hunt promises 5,000 new GPs in 5 years' time. There's a gap. We have a funding promise. We have a funding issue. We have the requirement to provide a 7-day service. We have a requirement to meet the standards for the services. As you all know, there is the 2-week wait regarding cancer services. That never used to be there 10 years, 15 years ago. We have that. We have to perform to that. Services have improved dramatically. Outcomes have improved dramatically as a consequence of that. We are, in North Devon, one of the top performing trusts in the country. You may not believe that, but we are. Thank you. And we don't want to slip from that position, and that's why we do make tough decisions to ensure our services are safe and effective going forward. So those are some of the challenges, and as we were saying, we have 3 key areas as part of this acute services review that we are needing to look at. And this is all the sharp end of where we interact. And as you'll see, most of the things I've already said are repeated in that slide. But I think common sense would say, as we all know, there is this thing called the golden hour about time to treatment. I'm sure no one's going to accept a situation where that deteriorates and you do not have access to the services you require in that time. Stroke services. Similarly, the same problems are there regarding staff, standards, and so forth. Similarly, at the sharp end, no one's going to accept that the safety of the patient should be affected by travel times. There is a time window in which those clot-busting drugs have to be given. However, there are other parts of the service which are not so time critical, where it is important that you have the appropriate number of patients to ensure that the patients who suffer from strokes and so forth actually get the best interventions to make the best recovery. And I don't know if anyone's lived or has a relative with a disability of a stroke. I'm sure you would all appreciate that those and yourselves have access to the best services that are going to make the best opportunities regarding your recovery. And I'm sure we would all like those services to be next door. But reality is not going to allow that. So I'm sure many of you, and I hope all of you, will accept the need to travel further for those not time-critical services. Similarly, maternity, children's health and so forth. If you need an emergency section, you need an emergency section, and you need it promptly. Therefore, those services will need to be provided. I cannot see anyone accepting that patient safety should be endangered by not having the level, the timeliness of intervention that we currently have. So as I say, no decision has been made, but as you can see, the criteria that we are looking at, and this is the bit, before making any decisions, we need your input into this, the criteria. There are 7 of them, and at the top, I know it's a very small box, but it says safety. And what we said, delivers improved patient safety. Well, and I will point down further is access, and that's maybe the timeliness of interventions and so forth. And it's your feedback into that. That's what we've said, but I'm sure you've got much better ideas about what you think is important in the criteria, how the criteria are phrased, that we can then use, or can be used, to make an assessment of the options that are going to be put before you at some point in the future. And that is what today is about. So I'm not going to say any more. I think obviously you want your chance to ask this question, so I think let's get on with it.
Well done, Chris. Thank you. So we'll get straight on to the plenary session so that people have the opportunity to ask questions. The panel members, I think. Just before we go any further, ladies and gentlemen, I gather there are 2 blue badge holders parked on the road who haven't paid for their parking. And I'm asked to advise them, please could they do so, as the parking warden is aware. So if that's any amongst you, please could you sort that out as quickly as you can. So plenary session, I will open it up to the floor. If you've spoken already, please keep your hand down until you've given other people an opportunity to speak.
On the road, there was no sign saying I had to pay for it.
Okay. I can only tell you the note that's I've been left, which is that you do need to. I can only tell you I've got a note that says you need to pay for your parking. There aren't parking machines in the car parking areas. So I suggest, sir, you perhaps. I mean, if you want to take that up with the college, it is their business. So we get on. Okay. I mean, it's entirely up to you whether you sort that out or not. But. I'm sure the lady at the back there might be able to go down and ask at reception whether this gentleman who's parked where, sir? Well, I suspect the answer is that pay and display right across the site. And if you haven't paid this display, you risk getting a ticket. And then you'll be tangled up in the appeals process with the college, not with the NHS or the town council. So I'd encourage you to go and sort that out if you go and pay for your parking and ask questions later, perhaps. So let's focus on questions for the panel, who I think will introduce themselves by Dr. John Worsley. John, so that the public are aware.
This one works.
Switch it on. Switch it on.
Hi, my name is Dr. John Worsley. I'm a GP in Ilfracombe, been there for the last 30 years, and I'm chair of the Northern Locality of the CCG. That's the commissioning body.
Thank you. So let's crack on. I'll try and be flexible. I'll try and extend this a bit. Let's crack on with some questions as brief as possible.
Could you tell me, please, how many ambulances there are in North Devon? Because somebody in Coombe Martin had to wait for an hour and a half the other day for the arrival of an ambulance. That was before they got to receive medical treatment at the hospital or wherever. If patients here have to go to Exeter for treatment, it means that an ambulance is going to be out of use for any other emergency for the whole 2-hour round trip, which is really going to severely deplete the emergency response available in North Devon. And I'd like an answer, please.
How many ambulances in North Devon?
Hello. Hello, I can't answer how many ambulances are, but it's a very important question, and we're here for the Acute Services Review. I can tell you that the SWAT, who's the ambulance service provider, have been at the meetings, and this issue has been raised. And there's no doubt that if any services were to change, and that could be here, or in Plymouth, or in Corby, or in Exeter, there would be an impact on SWAT, and that would need to be looked at and planned for. So you're right. In any change, the ambulance service side of things is vitally important, and they are part of the conversations.
Could I suggest that to inform the public debate and decision that data on what is time critical and on outcomes, we just have headline stuff on outcomes, we don't have real data on outcomes, should be put into the public domain in a way that can be readily understood. Then the debate can carry on some basis. Also a question about the 800 million contingency fund that at national level which was thought to be being used for mental health and other services, is now being deployed to bail out the acute trusts. Is that going to impact on this process?
Dealing with the second question first, right? No, because this is about the plans we are wanting to develop will be about the earliest things that change would be financial year after this one about to start. I would imagine that 800 million is a this year financial issue. It's a one-off, it's not a forever in relation to that. And I've already forgotten your first question. I'm sorry.
Data, to have a decent...
Oh, the data, yes.
Data on time criticality is
Yep.
obviously a key issue.
Yeah,
and the components of services which are and which aren't. And the other thing is outcome data. NHS is pretty poor on real outcome data as to whether people get better or whether it's sustained and so forth.
I completely agree. We're pretty good at measuring when things go wrong. So we can measure death rates and we can measure complication rates and things like that. Measuring how much better people have got is much more difficult.
But if you're going to have a debate about access, then you need information
yes.
about outcome.
Yeah.
For
So,
instance.
okay. So in terms of the data, there was a lot of information provided in the Case for Change document that was published just over a year ago. But you do make a good point in terms of where there are concerns, where it is recognised we are not meeting national standards or expectations, then we need to make that clear.
A good point. So the criteria should be based on data from outcomes.
Are you the same Dr. Chris Bauman that took the lead at North Devon Council with the removal of stroke rehabilitation back into North Devon District Hospital?
I am the same Chris Bowman who did present to the town council.
Because at that meeting, you told us that stroke was not time dependent, and you just spent ages telling us that some of these things aren't quite important.
I didn't say that. I said, well, if I did, I apologise, but I don't believe I said that. My memory is not perfect in every detail. What I do remember saying is that clot-busting drugs need to be delivered within a time frame of 4 to 5 hours. Now, so there is a time limit. As on the side, I won't go into the detail of the side. One of the key issues we have with stroke is the identification of a stroke by the individual. That in itself introduces a delay in seeking treatment. So, I don't know, I mean, I'm not sure what your point is, but my point today certainly is yes, there is a time limit to it. So, I'm sure that favours, I'm not sure.
My point was that you spent a fair bit of time talking quite eloquently about all the safety measures that there are in place. Although when you were in front of the executive, you did say that stroke was not time dependent, and at the time I found that at best misleading, if not malicious, in terms of trying to lead people into the end status that we want to have stroke away from North Devon and put it in Exeter.
Okay,
well,
just before Chris, just before we go, I mean, we could spend a little while saying he said, she said, and what we didn't say. So I think that Chris has set the record straight in terms of what the position is, and the important point today is not only that we have information on outcomes, but on the clinical and medical requirements to achieve those outcomes. So hopefully the criteria will be supported by that information too.
Thank you. Different question from my previous one. How are you going to pay for the community services in people's homes? 24-hour care, in other words, in people's homes.
By moving resources around as people who might have experienced what's both in Torrington and Ilfracombe, and those beds in those community hospitals closed, the money that had previously been used to keep them open was then invested in more community nurses and therapists to help look after patients in their home.
So the NHS is going to pay for those?
Yes.
What about personal care for people in their homes that they would have received in the community hospital and wouldn't have had to pay for?
Well, the experience from elsewhere across the county is that there has been no impact on the local authority requirement to fund care, whether that be in residential or in the individual's home.
They're at home. Who is going to pay for their personal care at home?
Moving on to the next one.
If I could just say something, please. When I telephoned Exeter to find out what this meeting was all about, I was told that I would be presented with a plan by clinicians as to what the NHS is going to look like in North Devon. Right. So what I've got here today is a wish list. It's on that list, it's everything we all want. Safety, quality, access, service extended leave, the whole caboodle, right. But what we can't decide today is how that would look. I needed you guys to say, this is what the new structure would look like if we had a blank piece of paper. What do you think? I have nothing to contribute. I need to comment on your plans, not faffing around with what might be a priority. But because my main concern is, I've been here before. Can anyone remember the way ahead? Devon County Council Social Services, I was a district councillor at the time, and the way ahead plan never went anywhere. I called it the way behind. Nothing happened, and that was the integration of services, NHS and social services. That clearly hasn't happened. And what I think I'm pretty disappointed with, I noticed that the Lord Carter report, it came out in 2015, February. 2 years on, you're saying that you will implement Carter's recommendations on saving money by joining forces. So why haven't you done it already? I'm actually going to pop a phone because I can't see any point in being here, to be honest.
Okay, well, do you want us to respond to that point before you leave, sir? Did you want to listen to any response to that point before you leave? Okay. Well, where are you going to address it? I don't know.
Okay. I think the points made deserve a response. In terms of, I apologise that if you came here expecting something different. This is as I said at the start, this is the first step in a long process of engaging with the public. So we're not at the point yet of saying, here, this is what we think it looks like, what do you reckon? We're at the point of saying, before we start that process of working out what services might look like, we need to know what's important to you, so that when we come to look at those services, we can say, does it tick these boxes or does it not? If it doesn't tick them, then we need to think again. And at that stage, we'll be coming back out to you. And in relation to Carter, progress has been made. However, to a great extent, this is actually, we're waiting on initiatives from the centre in terms of saying, look, these are the areas in which you really need to concentrate. The plan was very high level.
Okay.
Yeah, I'm agreeing with the guy just behind me, what he's just said, because you're asking us to sit here and actually collude in making cuts, or sitting at tables deciding what's better for individuals here, rather than seeing it in the round collectively that any cut is a cut against any person in this room. And I would add that your combined salaries on the North Devon Health Care Trust are 855,000 minimum. We're in a range of 5,000 for each, that goes up to 925,000 minimum. With added pension benefits, it goes up to 1.7 billion maximum. And 1 million, not billion. The figures are eye-watering, so I've made a mistake there. There are people on your CCG and your Devon Healthcare Trust who have private healthcare interests as well. Mr. Ribbs, you've got 5 Square Solutions in Plymouth. How do you square the fact that you're on such a fat salary and can still make decisions about public health while you're taking private health money as a director of a private company? And you're just one person on that group.
So one person who has been willing to come and talk to you today, I would also add some, perhaps, I don't know whether anyone wants to respond in any way to that, or...
Well, I think probably, I'd like to get back on track to what previous gentleman said, which was about plans, etc. This page here is about local services and services across Devon. It's not all green. It should be all green. And so when we've assessed services, we find they're not as good as they should be. So very briefly, what happened was 2015, and we had a look at our services across Devon. We found that they were not as good as they should be. So that was called The Case for Change, which I hope people have read, because people need to read it without being too scary. Our services are not as good as they should be. So we found that some services actually were more vulnerable, more likely to fall over, more likely to fail than others. And amongst those services is stroke services, maternity, A&E, etc. So that group of services has been looked at in greater detail by a whole group of senior consultants in the area. So it's a local body looking at this. And each of these areas are being looked at, and partly what we need to know as clinicians, because I'm attending some of those meetings, not all of them, we need to know what people think, what's important to them. So again, if we look at the page that he quite rightly held up there about what's important to us as clinicians, we already have at the top of that list safety. And then down in access, I think is a really important phrase, which it says, waiting time standards for that service. And that's absolute. So this gentleman here talked about time critical services. He's absolutely right. Anything which needs to be looked after within a certain time by national standards is absolutely vital that we have those services provided locally. So the plans we'll be looking at, and we have looked at so far, what's wrong and what's right. We've looked at the money we have available to provide the services. So we have a national allocated funding, and we have funding for various services, and we have to work within that amount of money. So money is one thing. More importantly, I think, actually, is the workforce to provide those services. Now, I have seen that there is a significant workforce problem in the NHS. Somebody, I think a lady there said, well, why is that the case? The case is they got the workforce planning wrong. It's as simple as that. There are not enough clinicians to provide the services. So with a lot more money, we could not get clinicians to provide all the services to the very top level. They're simply not available in this country at the moment. So we have to work with the funding we have and with the clinical body we have. And with that group, we want to have the best services possible. That's quite a challenge. But we need to have urgent services provided locally within the national timelines. That's number one. If we have a bit of time, then we have to look at those other services. But the important thing is to have those urgent services. And that's why it's called an acute services review. That's what we all want as patients in the NHS. So it's a challenge, but that page there should be all green, and particularly the top line, which is safe, has not a single green dot in it. So when we looked at our services, and that's assessed by CQC, they said they could be better, and that's what we need to do, and that's what this is about. There are no set plans, which is why the gentleman was disappointed. There will be plans at the end of this that we will say, here are the scenarios, here are the options we could put forward, and that's when we'll come out to have a formal consultation.
That'll do for part of the answer to the question. There was a second element to today's question. I don't know whether any of the panel want to address the issue of whether there's any conflict of interest amongst the decision makers in the process.
Yes, I'm pleased that it was brought up, because I did see this circulating on Facebook yesterday, and would like the opportunity to put the facts straight.
You do that generally rather than
to run an NHS trust, you require a board. To require a board, you require senior managers and non-executive directors. To require those, you need to pay salaries to them. Some of the figures you used were incorrect, and I do have to respond to the personal accusation in relation. Would you like me to respond in relation to myself? The fact that I am a shareholder in a company that runs a healthcare consultancy does not mean I run private healthcare. To be clear, the NHS relies on some highly specialist individuals for bits of work that are so rare, thankfully, that individual organisations cannot employ them. That company that I am a shareholder in, my wife is the predominant shareholder. She does investigations into mental health homicides. So when a person who's been in contact with mental health services and kills somebody, by law you have to have an independent investigation. Thankfully, those are rare.
no one mental health provider would ever employ their own investigator. They just would thankfully have enough work to do. That's what my wife does. However, to ensure there is absolutely no danger of any conflict of interest, she will not take any, should there be a case in Devon, she will not take that case. Okay?
You're a director. Are we done?
Your point is?
Move on to the next question.
What I took from your presentation was you were saying that there's lots of inequality across Devon where services provided and things like that, and actually I don't understand how removing services from this area and making people drive for further is going to make that less unequal. Surely that's going to just make the problem worse. I really don't understand how that's the way forward.
I don't think any of us would disagree. And as I said, there are no decisions have been made. That's why we're looking at the criteria today. We need your input into that.
Sorry, as a nurse and as somebody recovering from breast cancer, the whole, as far as I'm aware, everybody's incredibly frightened by these rumours about the closing of the A&E and the closing of the maternity services. I had my radiotherapy treatment in Exeter, which made my whole experience as a breast cancer patient a lot worse for my whole family. You know, to remove services from North Devon when we've got a growing population will absolutely devastate the whole of this area. And I do not understand why, you know, you can't look at getting some more funding from other areas, you know, rather than punishing local people, because that's what it feels like. Torrington, Holsworthy, all these hospitals are being closed, and it's without, and you say it's with public consultation. Nobody wanted, in the public, wanted those hospitals closed, and you closed them anyway. You did not listen to the democratic voice of the people there, so why should we believe you now when you didn't listen to the people there?
So there are 2 points there. One is, why are you looking at getting additional funding rather than changing services? And the second point is, how does the process, how do we have trust in the process?
The additional funding, I think that's a national issue. That's down to...
The government's put a lot of money into free schools. Wait space. Why can't that money be converted to the NHS?
And you have your choice at the ballot box to select a government that's going to do that. As public servants working within our trust, then we have a requirement to deliver those services within budget. That is our duty as the employees of the trust. But as public, then you have the right to vote in a government that is going to support extra taxation, which will fund extra, or provide extra money for the NHS.
A good point.
Thank you.
So, about trust in the process.
Trust in the process.
How do people trust in the process? Why should they?
Because none of us want those services closed.
Point taken, point taken. Once again, and then there wouldn't have been any public engagement, and you wouldn't have felt you had a say. Okay, taking your point about why have we closed, and I think we need to differentiate. Certainly Torrington, Ilfracombe are permanently closed, whereas obviously Holsworthy is temporarily closed. Sorry, my apologies.
Oh no!
Okay.
And you
So,
smile off your face because people are going to die as a result of these cuts.
sorry, which
People are going to die as a result of these cuts, so you can take the smile off your face.
well, surely as health professionals and someone who's lived and worked in North Devon for 30 years, that's not something I'm going to put my vote to. Is it, Mr. Waldman? Well, that's your opinion, but I have my...
John, why are you not fighting our case? You're our servant. John. You should not be working for the CCG.
Please sit down. There are other people waiting to ask questions, and you pushing in front is not helping. This lady's next.
Well, can I just answer the question around...
Sure.
These are tough decisions around the hospital, community hospitals we close, and obviously there's still continuing disquiet around the decision around Torrington. However, the evidence does show that we are able to support many more people in their homes as a consequence of those few bed closures, and we have been able to reinvest that money into those services. So the outcomes for patients have not got worse. Overall, I would suggest they have got better.
You've got home carers who are paying really low wages.
What you have to accept, what we are responsible is for the period of care when a patient would have otherwise been admitted into a hospital or has been discharged home early until they've recovered. We are not responsible for the long-term ongoing social care that patients receive, and that is available whether or not you've been into hospital. But for the period of time where you would have otherwise gone into hospital, then that is funded by the NHS.
Okay, this lady from here.
Okay, I'm one of those nervous people, so you'll just have to bear with me. I'm the mother of a severely learning disabled daughter, living in Bideford, and we've had frequent admissions to the paediatric ward at North Devon District Hospital. My question is, it says upon your board there, joined up services, making it easy for you to access care. How will a relocation of the paediatric department to Devon, to Exeter or Plymouth, make it easier for me to access care for my learning disabled daughter when I live in Bideford? I already have to drive quite frequently from Bideford to North Devon District Hospital to get my daughter the care that she needs, which is time critical because her blood sugars will drop and she gets it poorly very quickly. Having to do that and actually drive to Plymouth or Exeter frightens the hell out of me, to be quite honest with you. We want services close to where we live, not relocating to Exeter or Plymouth.
Good point, well made. Just to reiterate, there are no proposals at the moment, but where there aren't rules on that chart, we are duty bound to look at them. And some of the areas in which we're not green are because we're not meeting nationally recognised standards. So as an example, I don't know paediatrics in detail, but as an example of obstetrics, the Royal College says that you shall have a consultant obstetrician in the delivery suite, something like 16 hours a day, 7 days a week. If you look at how many that means, you need 10 consultants. But then with the next breath, they say each consultant should be responsible for, I think it's 350 births a year. So therefore you need 3,500 births in a year for a unit. Barnstaple only has 1,500. So on that basis, we cannot meet the Royal College standards because if we have 10 consultants and they're not doing enough deliveries, if we have the right deliveries per consultant, then we cannot physically have a consultant in the delivery suite, not at home on call, 16 hours a day. So the question had to be asked. That doesn't mean, just because we ask the question, it doesn't mean that maternity services therefore have to move. And I was told yesterday that it is recognised at the very top of the Department of Health, i.e. Jeremy Hunt, it is recognised that Barnstaple is a special case. Now, we all know it's special, but it is recognised that its rurality and its distance from other acute units means that it has to be a special case. Whether that means, that's not going to mean we can chuck every national standard in the bin because we could just say, oh, we're special. But it does change the nature of the debate. It does recognise that for small, isolated communities like this, you cannot impose willy-nilly national standards that have been designed for hospitals in London.
Hi. I've been to one of these before. It that was presented by Alison Diamond, the Chief Executive of the Health Trust, in which she gave the same presentation. And she was asked by somebody what was good about the SDP, and one of the parts of her answer was pointing at all those emblems you started on the first slide with all the different organisations. And she said that having all these same people in the room together allowed solutions to be created much more effectively, and made it easier to manage the difficult issues and problems that you pointed out during the presentation. Now, I realise that the organisational structure of the NHS and councils isn't in the gift of the SDP. However, there is no reason, tell me, is there a reason that the SDP could not recommend that changes are made to organisational structures that free resources to allow the issues to be addressed?
I agree with you. Absolutely right. That's a really good point. I think because we have funding issues, workforce issues, morality issues, we can't solve this by ourselves in North Devon. So there is some strength in having the whole system looked at, and the Acute Service Review is not a review of Barnstaple Hospital. It's a review of the NHS system in the whole of Devon. Part of that will be, if we haven't got a workforce that is sustainable in a small unit and the reasons we heard there, actually, should we be asking our workforce to travel more? So somebody works for 2 days in Northern Devon and 3 days in Exeter, say. I think that sort of solution definitely needs to be looked at. That way the clinician would have the accreditation they would need, they'd see the number of cases, and we would still get a local service. So could the form of the NHS change within Devon? That could well be the end result of an Acute Services Review. Because what we have at the moment doesn't work that well, and it's a real challenge. Without labelling the point, I think the doctors and nurses and clinicians, the pharmacists and the physios are struggling to keep a good service going. But if we did it a different way and kept as many services local as possible, I think we could have probably a better, safer service with clinicians that were better rested. So you're right, if we looked at doing things differently, I think that might be the solution. And the strength of the SDP is, in those rooms we have clinicians, consultants from Plymouth and Exeter and Torbay and Devon, and they have been having conversations like, well, should we share our consultants? So we already have ENT services from a consultant in Exeter comes up here. Now, I don't care who employs them, providing we get a local service. We have a neurology service that comes from Exeter. I don't care where they come from, providing we get a local service. So by doing things differently, definitely, I think that might be the way we go with this. There's no plans yet, but as it narrows down to what's safe and what isn't safe, and the travel times and the time critical bit rules out all sorts of options, they're just not safe, I think we may look at asking our clinicians to move around a little bit more.
That's not organisational change, though, isn't it?
People waiting to ask questions. We are running over a little bit, but we'll carry on.
Yeah, it's a simple question. I'm puzzled. Maybe I'll be a bit simplistic, but I keep hearing, right from the very beginning, you're saying we don't have any plans. I've been following the SDP, and this Acute Services Review is part of the SDP. I've been following it for the past year. And first of all, in June, there was a draft planning document put in, and then in the autumn, October, I think, was the final plan document put in. So how can you say that there aren't any plans when, or was that all just
Johnny again?
My personal view is I think plan is probably not the right term for it, because if you look in there, if you read the STP, it's actually what needs to happen to get better services across Devon. It doesn't say what those changes should be, what any form changes should be. It says, here's what we need to go through. It says we need to look at what's wrong, we need to look at who we get together to look at what we need to change, and it sets out a time scale. So it actually is over 5 years. So if as a result of the acute service review we feel we need to make some changes, actually that process won't start on the Monday morning. You need to have all sorts of plans in place so that can happen safely over probably a couple of years. Some things might happen more quickly because some services are an issue. Stroke services, I think we need to look out across the whole of Devon. We have to make some quick decisions there because we are struggling to provide those services. But as a plan, we're going to do A, B, and C. If you read the document, actually it doesn't say that. It's the wrong term. You're right.
In fact, the final plan has the timescales taken out, which was in the draft plan.
That may be because actually to put some of these changes will take a time, and there's no doubt about it. So it's not, people, the lady over here said, withdrawal of services from Barnstaple Hospital. That has not been proposed. And when I hear the clinicians talking about the way services need to change, so if we talk about stroke services, say, I have heard in those rooms, we need stroke services in North Devon. I think that's a gimme. We do. You look at an A&E. I think we need an A&E in this area. I think you wouldn't find a single clinician in Devon who thinks we don't. But how we deliver those services and what level they are provided at needs looking at. So as far as stroke services go, you can have a hyper-acute stroke unit that has the all-singing, all-dancing consultant 2 ward rounds a day. We will never be able to provide that in Northern Devon. But we will be able to provide an acute stroke unit, which is a slightly lower level. And it's actually what we've had for the last umpteen years. So that would be no change for us. So we do need to just look at, this is the whole of Devon, not just North Devon.
I would like to say that I'd like to pat John on the back for his thinking outside the box, because perhaps people will have to right, that they will have to travel from South Devon up here as consultants, because we haven't got them, and this is everywhere. This is throughout the whole country. There are just not enough medical people. And I take the gentleman, and I can't remember his name, I'm terribly sorry, the gentleman in the suit, who says we probably cannot keep up the standards that are required of us. But having said that, I think that most people up in North Devon would prefer to have some service than the absolutely perfect one, especially if you are in labour and you are having a baby. I live in Brendan, which is further than Linton, which, as you know, would take us today 3/4 of an hour to drive here, let alone going to Exeter. And in the bad weather, and with the travel things, I mean, we've had a lot of road closures just recently, and it's taking us 1.5 hours to get anywhere. And with the ambulance service, we've just had our ambulance taken away, which is going at the end of March. We rely on the helicopter. There's only one, and it is a charity. It isn't run by the NHS. What are we supposed to do? I worked in the NHS for nearly 50 years, and my last job was on the community palliative care out there. Now, we cannot get people to come out. And if you're going to overload the community with more and more people who are going to be at home, who's going to look after them? And if you keep people well, so they get older and older and older, at the end, they all come to the end, but at the end, they are worse off.
So at the back here, a couple gentlemen and 4 hours.
Just a quick answer to Susie. I think there's something about timeliness of intervention. So certainly if we're able to intervene in a timely way and provide the best service we can, then the real issues around complications and making sure the outcomes are the best. So, I mean, I'd absolutely agree with John. You want a model, ideally, that provides the expertise so that you get that expertise as quickly as possible, get the best care that's available, so first time, so that we minimise complications, because it's complications that really cost the NHS. And that's where I'm coming back to beds and hospital beds. Because the evidence is there. There is loads of evidence that the longer you stay in a hospital bed...
With the best of if you were in labour, and you're never going to be in labour because you're a man, but if you're in labour and somebody says, well, you've got to wait for an ambulance and you have no idea when it's coming, and then you've got to travel all that way, and you're a perfectly normal...
I'm not disagreeing with any of that.
Why would you want to trek all the way to Exeter?
And I think...
Sorry. A baby who has to go to the
Sorry, I think John's answered that. I don't think we're looking at... I hope we're not looking at a solution that has our obstetric services only based in Exeter. That would be ridiculous.
What about the Premier Union?
I think, as John has said, I think one has to look at all those things and find solutions that actually are network solutions where we use staff to cover all these things. And are there other solutions, recognising how extreme remote some of the parts of North Devon are, that actually provide a better outcomes than we do at the moment, which aren't necessarily hospital based.
James, that's better, thank you. My background in the NHS was about 4 years ago when I was a maintenance electrician in the then North Devon Hospital Management Committee, which was run in Barnstaple. We had the North Devon Infirmary, Alexandra Hospital, and a few others. We were responsible as a maintenance team, an in-house maintenance team. None of the out people that you get in now. My question to you is, you mentioned earlier, and please tell me again, the deficit that we're in at the moment, please. That's question one. Question two is, how the hell did we get there anyway? Because my opinion is, when it was run years ago, we didn't have the likes of yourselves and so-called quangos, as I would call you. You had a North Devon Hospital Management which was very efficient. It strikes me that the deficit has nothing to do with the amount of people dying or aged or being looked after. It's the people who are earning money, in inverted commas, and I would stress that word earning is certainly not what they're doing. Claiming is the word. How much of that deficit is the result of all these quangos which have been set up, please?
Certainly, the first part of the question was how overdrawn are we, and the answer is for this year £100 million. So every year we have not been able to provide services across New Devon, that's leaving out South Devon Torbay, across New Devon without borrowing money from the government. So it's been 40 million the first year, 40 million the second year. So we're now up to about 100 million, and I think the charts in there say if we carry on like that, it will be 500. Yes, more money would be lovely. I think that would be. I think we all know that. That's not the only part of the solution. We do need more staff, and we do need to do things in a different way. Dr. Holmes talked about looking after people in beds as opposed to the community. I think in the community hospitals, we can probably look after about 4 times as many people at home, if that's a safe place for them to be, compared to being in hospital. And I do welcome the budget statement that said they're going to give a lot of money to social care. That's absolutely right. So for Devon, I think that would probably be about £15 million for social care in the first year, and about £50 million the second year. So actually, the system is starting to work better together. As far as whether anybody earns the money, I think that's not for me to answer. What I can say is I see everybody working very, very hard to try and make a very complicated system work. And it involves, as we heard earlier, SWAS, the maternity services, the air ambulance, all these services interact. So it is complicated, but I do see people working very, very hard there.
Thank you. I'm going to take one more. I'm going to take one more question for now. Then, if you're disciplined in the table discussions, there might be a few minutes at the end to ask for some more.
Thank you. My interest is access to eye care services, and my question is: do you believe that community optometrists and opticians can relieve the burden of access to the secondary care eye clinic through funding of a minor eye condition scheme in opticians' practices and other eye disease management schemes.
Could we provide the eye service differently to what we have now? The answer is those sorts of things definitely need to be looked at. We're always looking at ways to provide many more services in the community. So does a patient want to sit in an outpatient clinic that I understand is pretty busy? I've heard the word bedroom. But it is very, very busy. Would they rather go along to their local optician, provide actually locally? I think that needs looking at. I think, yes, we are open to looking at lots of different ways to providing these services.
Thank you, John. Okay, so there may be another opportunity for some more questions at the end. We'll crack on and do the bit that they want us to do, which is the table discussion. So we've already extended it by 20 minutes. No, not now. We're going to do the table discussion now, and if you stop asking questions now and do the table discussion, if there's time at the end, we'll do some more. Thank you, Dave. I hear you.
There's a solution given from the floor. They throw it back and say we're looking for solutions. People have been asking questions of why they're breaking this up.
Thank you, Dave. So, ladies and gentlemen, if you're at a table with just a few people at it, if you could join other people so that we've got full tables, there will be a facilitator at each table. Dave, you're just holding the process up now. So, okay, well, don't collude then.
I'm not sitting here taking part in the demolition of our what they wanted to do. They wanted to decide the criteria.
Ladies and gentlemen, there will be a facilitator at each table to facilitate your discussion. Thank you, John, for your input. I believe there's a slide showing what we're aiming to achieve from the table discussion. If you're leaving the process now, please can you do so quickly and quietly for the benefit of those who do want to stay and engage. Please, ladies and gentlemen, take your seats for the table discussions. Councillor William. Ladies and gentlemen, we will start the table discussions now. I need everybody in the room to stop speaking. Thank you. That's my town clerk voice. So please, quiet please, so that we can start the discussions. Please take a seat at the table and feed back to your facilitator. Thank you very much. We're starting with the STP. And I'll give it 10 minutes, see how we go. If anybody's lost a wallet, there may be one found under a chair somewhere in the room. So please let me know. How are we doing on the STP? Nearly ready to roll on. Couple more minutes on the STP and then you need to move on to the Acute Services review.
All I understand is
So over the next couple of minutes, can we roll on towards the acute services review discussion? Maybe 10 minutes more questions. Ladies and gentlemen, can I ask you to wind down now, please? We'll just do a brief conclusion session. So hang fire for a moment. I think that'll do, ladies and gentlemen. Feel free to stay on your tables. If I just draw the panel back together. Where Chris has gone, he's still there. Chris, in case you needed questions. I'll talk about that. 28 March, 7 o'clock, Guildhall. We're down to one microphone, but I will hand it around. If anybody has any key points or questions they want to air now, please put your hand up. Okay. Oh, there is one.
Do you think you prioritise enough prevention? I'm thinking about healthy eating and use trying to infiltrate as widely as you can and affecting government decisions on food. I just feel it's an obvious thing.
We're down to one microphone.
I don't need a microphone. The answer is yes, it's one of the main work streams, prevention. You're absolutely right. Unless we actually address that, we will have more and more problems in the future. Is it enough? Actually, it can never be enough, really. We work with the council and public health. Well, public health left the health service with a wonderful government reorganisation, but we still work with them, and they look at the wait services, all those sorts of things. So it's absolutely vital that we spend a lot of time and energy and effort and funding on disease prevention and health promotion. Absolutely.
Do you visit schools to do that?
We don't, but public health do.
But they've been cut.
They've
been drastic.
Yeah, I know. It's madness. No, I agree with you, because that's our future. That's our future well-being.
I just wanted to ask about, when you talk about accessibility, are you going to consider the relatives? So if you're talking about transferring people to Exeter, I live in a village where there is not a bus service, and I just wondered if you are going to consider not just the patients, but, because having friends and family around them is important to rehabilitation, etc.
Absolutely so, yes. So we've had two assessment processes. One is the patient, and the other is what we call the carer. So the patient sometimes actually is not that important because they're in an ambulance or they've been looked after by the NHS. So for some of the services we've said, no, that's not a criteria at all. But you're quite right. The carer's travel distance is absolutely vital. So yes, it's part of consideration. If it's urgent care, then we just need good, safe local services. Yeah.
Okay, any more for any more?
Just clarify the process. So when Vascular moved to Taunton, in those days there was the intermediate level of NHS organisation, wasn't it, in regions. Has that gone now? Because obviously a lot of people in Exmoor, they're far from everywhere, but Taunton's as close as Exeter is as close as Barnstaple, not quite as close as Barnstaple. So what way do you figure in what services are just over the border in Somerset?
Yeah, so patients go where's nearest often. So we had the same issue with Cornwall.
No, but your planning is that you used to have that intermediate level that looked, wasn't national, it wasn't Devon, it was the southwest.
So we're now at the southwest. So absolutely, so the CCGs meet, 4 CCGs meet every month, and there's a clinical network. So there's a stroke network, there's an A&E network, and that's the southwest. So that goes to half of Somerset.
Are you comparing and contrasting with STPs like Cumbria, where there's similar geographical and other challenges?
Similar, but not the same. So yes, we look at other STPs, and interestingly, Isle of Wight is quite similar in some of their challenges because they're sort of isolated a bit like us. So yes, there's lots of cross-learning, and teams are going up and down, and we are trying to learn from each other, yes.
Which actually was the same question in slightly different wording. Whilst the Department of Health says it's devolving decision making to local level in the NHS, it would be nice to also know that at the end of 44 STPs that there will be some consistency, in fact considerable consistency of services delivered to the National Health Service as well, and so lessons will be shared, experiences will be shared. Is that happening? How heavily involved is the Department of Health for good or evil purposes?
I'm going to miss out the good and evil bit. Yes, we meet with the DH on a regular basis. There is cross-learning. Actually, I'm for localism. I'm a director of One Ilfracombe. And I think what's going to happen with the STP, Devon's a big area. And I think we'll move towards 4 areas, which will be north, south, east and west, and look at the aim would be to eventually have an outcomes-based, capitation-based delivery system, because the solutions for us in Northern Devon will necessarily be very different to those in Plymouth and those in Exeter. So I want fair funding, I want recognition of our rurality, and I also want to be able to do it differently. But at the end of it, actually, we need to have as good outcomes here as they do over there. But we'll get there a different way. And it may cost more per head, and I think there's a recognition that that is always the case in rural populations. But that should be our aim.
Thank you very much, John. Okay, so a warm thank you to everybody who's attended today, to the organisers of the event. Thank you for your attention and organisation today. Thank you to the panel members for bringing their hard hats and facing the questions, and to the facilitators, each of you on the table. Thank you for your the feedback. The feedback and what happens with it is all covered by this slide behind me. Hopefully that's fairly self-explanatory. Let me just finish off and then I'll let you ask one last question. The feedback forms, the green ones, I'm told, are available online. So if there's anything else you want to say, then you've got an opportunity to do so outside this session. And one final thing from me, don't forget that there is an open public meeting at Barnstaple Guildhall in Butchers Row on Tuesday the 28th of March, at which Alison Diamond will take questions direct from the members of the public. So please feel free to come along, participate in a more open format of the forum. 7 o'clock.
Personally, I would like to thank everybody for this opportunity, mainly because half of the things that were going on before we didn't know anything about. So by talking to you about some of this, of how it's actually working in the innards, I wish that was propelled out to the people.
Okay, unless there's anything else burning. It's a very quick one, honestly.
When can we expect to see some kind of concrete proposal?
So the Acute Services reviews are still going on. We're sort of going to try and tidy things up in April. That's the clinicians' meeting. So what they think is the best way to provide services. Then there's the council election. So there's PERDA. So we're not allowed to even draw breath or say anything that might upset any election result. So then, so after PERDA, after council elections, then we'll need to take the proposals, which will be different scenarios. We'll bring those out to lots of public meetings to discuss the different options. Then we'll come back and say, okay, now we've got to make a decision. It might be quite difficult, but I remind people here, this is an Acute Services review for the whole of Devon, not just Northern Devon. And that's a really important point because it's recognised that we are rural, and I think we are different as well as being special. So there's a long part in this process to go yet.
But when you do get to that bit, is it like the US Senate, where each small state has the same blocking? You have 2 senators that block California or Florida.
So the good thing about the SPP is that there's a collaborative board, which is all the organisations, that's the chairs and everything else. Below that are the chief execs, the real power brokers. Now that group will need to get together and agree. So if there's a rogue unit, a rogue hospital that says, we're not going to do that, I expect, and will demand, that actually the other chief execs hold that individual to account and say, no, this is our system, this is what the clinicians have said is the best way forward, you are going to be part of that. And it comes down to it, I try and reduce their funding a bit, didn't play well.
Let's say Barnstaple isn't the rogue hospital. And that Donald Trump doesn't play any part in the process of American states. So thank you once again, ladies and gentlemen. Do feel free to take some of the green forms away with you. I think you can do that too.